Welcome to week 7, part 2. This lecture will discuss nursing management of diabetic ketoacidosis and also nursing management of inflammatory bowel disease. We're going to start with nursing management of diabetic ketoacidosis, and this is from your required reading, chapter 52. I'm not going to go into a lot of detail about diabetes mellitus. As you know, it's a chronic multi-system disease related to abnormal insulin production, impaired insulin utilization, or both. So it's related to the body does not produce enough insulin or the body does not use it appropriately. As you know, there's a type 1 and a type 2. Type 1 diabetes is a progressive destruction of the pancreatic B cells by the body's own T cells. And so it's an autoimmune disease. Autoantibodies cause a reduction of 80 to 90% in normal B cell function before manifestations occur. So people don't know that they have diabetes or type 1 until almost 80 to 90% of the normal B cell function is destroyed. The main cause is a genetic predisposition, and it's related to human leukocyte antigens. So predisposition to type 1 diabetes is believed to be related to HLAs. When an individual with certain HLA types is exposed to viral infections, the beta cells of the pancreas are destroyed, either directly or through an autoimmune response. The HLA types associated with an increased risk for type 1 diabetes include HLA-DR3 and HLA-DR4. So it's a genetic predisposition. The individual with type 1 diabetes mellitus requires a supply of insulin from an outside source, so an exogenous insulin, such as an injection in order to sustain life. Without insulin, the patient will develop diabetic ketoacidosis, which is a life-threatening condition resulting in metabolic acidosis, and if untreated, could be fatal. Now, before we speak more about DKA, I want to speak to type 2 diabetes. So as you know, type 2 diabetes is by far the most prevalent type of diabetes and accounts for over 90% of patients with diabetes. Type 2 diabetes usually occurs in people older than 35, and 80 to 90% of patients are overweight at the time of diagnosis. There is a genetic basis, and it's also found to be higher or greater in some at-risk populations. So, as we said, in type 1 diabetes, it's related to the inability to produce enough insulin. But in type 2 diabetes is that the pancreas continues to produce endogenous insulin, but the insulin produced is insufficient or is poorly utilized by the tissues. I want to come back to the risk factor of obesity. So obesity has been said to be the most powerful risk factor. And so why is that? Well, what they found is that the fat cells in the abdomen release an excess amount of free fatty acids, which are associated with insulin resistance at the level of the liver, as well as several other enzymes which cause insulin resistance in the muscles. And so obesity has a tendency to run in families and probably has a genetic basis as well. So genetic mutations lead to insulin resistance, and there's an increased risk for obesity with these genetic mutations. So let's look at one of the most severe acute complications, DKA. So it's an acute metabolic complication of diabetes mellitus occurring when fats are metabolized in the absence of insulin. So it's characterized by a profound deficiency of insulin, and the manifestations are hyperglycemia, ketosis, metabolic acidosis, and dehydration. It's most likely to occur in people with type 1 diabetes, but may be seen in type 2 diabetes in conditions of severe illness or stress. So the precipitating factors are illness in 20%, infection in 40%, inadequate insulin dosage or missed insulin in 25%, undiagnosed type 1 in 15%, and poor self-management. So what happens in DKA? So when the circulating supply of insulin is insufficient, glucose cannot be properly used for energy, so the body breaks down fat stores as a secondary source of fuel. Ketones are acidic byproducts of fat metabolism that can cause serious problems when they become excessive in the blood. Ketosis changes the pH balance, causing metabolic acidosis to develop. Ketonuria is a process that begins when ketone bodies are excreted in the urine. During this process, electrolytes become depleted because they are eliminated along with the ketones in an attempt to maintain the electrical state of the cells. So let's go into more detail here. So we have insulin deficiency. It leads to decreased tissue glucose utilization because insulin is the carrier for glucose into the tissues and muscles, and it's not happening. So you have the breakdown of fat, which causes the ketosis and ketoacidosis or metabolic acidosis. You have the breakdown of protein to try and provide another source of energy. And then you have the liver going into overdrive because it senses that there's not enough glucose in the body, and so it produces more glucose. And so you get the hyperglycemia, you get the ketoacidosis from the ketosis, and this is hunger. Your body's hungry, so it's your body saying there's not enough glucose, we need you to eat more, bring in more glucose, and so you get polyphagia, so an increase in appetite. So this ketoacidosis and this hyperglycemia start to affect the kidneys, and so what you have happening is the ketone bodies are being excreted in the urine. You get a high level of sugar in the urine. And so then you have this whole osmolality that happens. Remember I spoke in the previous class about serum osmolality? And so as a result of all these processes, the blood glucose levels are highly elevated. And so what you get is this increased serum osmolality with high amounts of glucose in the urine, and it leads to osmotic diuresis. And so this leads to polyuria, volume depletion, and then this polydipsia, so thirst. That's your thirst mechanism coming into place because you have volume depletion. The massive fluid loss from the osmotic diuresis causes fluid and electrolyte imbalances and dehydration. Water loss exceeds glucose and electrolyte loss, contributing to this hyperosmolality. So just remember when I said about the high serum osmolality, it's the pulling force. So the high levels of ketones and glucose are pulling water and pulling it and causing it to be excreted in the urine, hence the volume depletion. So the signs and symptoms are polyuria and polydipsia, so a lot of urine and an increase in thirst. Lethargy and weakness, which are your early symptoms. Dehydration, so goes along with dehydration are your poor skin turgor, your dry mucous membranes, tachycardia, orthostatic hypotension. So orthostatic hypotension is going from a lying to a sitting position, and you have a significant drop in your blood pressure. It's a great indicator of dehydration. An altered level of consciousness. Other things are abdominal pain, Cosmos breathing. Cosmos breathing is a rapid, deep breathing, and it's an attempt to reverse metabolic acidosis. And so people with DKA have this sweet, fruity odor to their breath. And oftentimes people in the emergency department think these individuals have been drinking because of this sweet, fruity odor, which is the ketosis. So what are you going to see in your lab values? Obviously, hyperglycemia, In the urine, you're going to have high ketones and high glucose. The sodium could be increased, normal, or decreased depending on the fluid status of the patient. If it's prolonged hyperglycemia, it depresses sodium, but dehydration can increase it, so it needs to be evaluated after the fluid resuscitation. Potassium initially appears increased, but actual body potassium is decreased. The bicarbonate, it depends on the diabetic ketoacidosis, whether it's severe, moderate, or mild. Your PCO2 tends to be low because you're hyperventilating, trying to blow off this acid. The pH is going to be acidic. Your CBC could be increased secondary to stress or infection, and your serum ketones are positive. It's a serious condition, and it must be treated promptly. Depending on the signs or symptoms, you may or may not need hospitalization, but you definitely will present in the emergency department. Remember always ABCs, so remember your airway management if you have a decrease in level of consciousness in your patient, so oxygen administration. You're going to be correcting the fluid and electrolyte imbalances. And so remember, this patient is volume depleted, and depending on what their sodium level is, you're going to be giving an IV infusion for the restoring the urine output, raising the blood pressure. When blood glucose levels are approximately 14 millimoles, so you're trying to bring the blood glucose levels down with insulin, but you could actually go quickly the other way into hypoglycemia. So once the glucose levels gets down to about 14, you may want to switch to a D5W, maybe added to prevent hypoglycemia. You're going to be replacing the potassium, and you may be giving sodium bicarbonate because it's a base to help with the reversal of the acidosis. Insulin therapy. So insulin allows water and potassium to enter the cell along with glucose and can lead to depletion of vascular tone and hypoglycemia. And so insulin is initially withheld until fluid resuscitation has begun. And typically you would start with a bolus followed by a sliding scale insulin drip. So let's look at this question. Cardiac monitoring is initiated for a client in diabetic ketoacidosis. The nurse recognizes that this measure is important to what? Identify dysrhythmias resulting from hypokalemia, fluid overload related to aggressive fluid replacement, the presence of hypovolemic shock related to osmotic diuresis, or cardiovascular collapse related to the effects of excess glucose on cardiac cells. And so for this one, the answer is 1. Electrolytes are depleted in diabetic ketoacidosis. Osmotic diuresis occurs with the depletion of sodium and potassium. And we know that hypokalemia may lead to ventricular dysrhythmias such as PVCs and bradycardia. So I'm going to move on to chapter 45, and here we're looking at nursing management of inflammatory bowel disease. So this is looking at all the causes and pathophysiology of acute abdominal pain. And so we can see that 2 of them, which we're going to speak to today, are Crohn's disease and ulcerative colitis. So what is inflammatory bowel disease? Well, it's an autoimmune disease that currently refers to 2 disorders of the GI tract, Crohn's disease and ulcerative colitis. And it's characterized by inflammation and ulceration. IBD is characterized by mild to severe acute exacerbations that occur at unpredictable intervals over many times. And we would say, or I would say, both diseases can be very debilitating. Crohn's disease is a chronic IBD of unknown origin that can affect any part of the GI tract from the mouth to the anus. Crohn's disease occurs most often between the ages of 15 and 30. When it occurs in older adults, the morbidity and mortality rates are higher because of other chronic problems that may be present. It occurs most commonly in the terminal ileum and the colon. The inflammation involves all the layers of the bowel wall, with segments of normal bowel occurring between disease portions, and you have these skip lesions, and that's one of the common things that you will see on diagnostic tests are the skip lesions. So this is an example of inflammatory bowel disease and these skip lesions. And so in Crohn's disease, you can see the dark red would be the inflamed areas, and then you have these skipping where there's normal. Whereas ulcerative colitis, you have a whole section that is ulcerated. We'll talk a little bit more about that in a second. So with Crohn's disease, individuals have bloody diarrhea and they have an abdominal pain that's very colicky. If the small intestine is involved, weight loss occurs due to malabsorption. In addition, patients may have systemic symptoms such as fever because of the inflammatory process. So the manifestations are exacerbations and remissions. I talked about the diarrhea and the colicky pain and the weight loss if the small intestine is involved. You can imagine there's fluid and electrolyte disorders, malaise, and possibly a low-grade fever related to the inflammatory process. Ulcerative colitis, on the other hand, is inflammation and ulceration of the colon and the rectum. So it's not affecting the small intestine. So you have diffuse inflammation beginning in the rectum and spreading upwards through the colon in a continuous pattern. So not these skip lesions. Inflammation and ulcerations occur in the mucosa and the submucosa, so not all three layers. And you can also get abscesses developing in the intestinal gland. So an intestinal gland is a gland that's found in between the intestinal epithelial lining of the small intestine and the large intestine. And so abscesses break through into the mucosa, leaving ulcerations. So just coming back to this diagram, in Crohn's, again, you have the skip lesions and it can involve the small intestine. Ulcerative colitis starts with the rectum and goes up into the colon, and there's no involvement with the small bowel, the small intestine. Clinical manifestations are these relapsing periods of diarrhea, bloody, mucousy stools, mild abdominal cramping, sometimes fetal incontinence, nocturnal diarrhea, anorexia, weakness, and fatigue. So the complications of IBD in general between the two diseases are obstructions and fistulas. Fistulas are a boring or an ulceration through layers of skin, malabsorption, dehydration, fluid and electrolyte imbalances, and anemia from the bloody diarrhea. Diagnosis, history and physical exam, a sigmoidoscopy or colonoscopy to look at the alterations and to find out if they're in the small intestine or their large intestine or both. A biopsy of a biopsy of tissue within the intestines. Maybe a barium enema to have a look through ultrasound or a CAT scan, stool specimens, ESR and electrolytes and CBC. ESR looks at autoimmune diseases. Invasive testing, and as I've already said, scopes is usually not done in the presence of active diseases. Treatment, drug therapy, surgical therapy, and nutrition therapy, which is cornerstone of the treatment. Some of the drugs are for inflammation, corticosteroids, immunosuppressants because it is an inflammatory autoimmune disease, aminosalicylates, antidiarrheals, anti-TNF agents. Lifestyle is looking at stress reduction, decreased physical activity. So looking at balancing that physical activity to not put yourself into stress, but also maintaining physical activity. Vitamins and dietary changes. And so the diet is really important. So you're going to eliminate high fiber foods, dairy, spice, caffeine. And TPN can also be used for bowel rest during acute exacerbations. And surgery is the last resort with a colonectomy with an ileostomy. For ulcerative colitis, the treatment is again corticosteroids, immunosuppressants, aminosalicylates, antidiarrheals, anti-TNF agents, again looking at the immune system and the inflammatory system. The diet is low residual diet. You may require supplements because remember ulcerative colitis could affect the absorption capabilities, and surgery is a last resort. So for IBD, if surgery is indicated, it's indicated if the patient with IBD fails to respond to treatment, they have frequent exacerbations which are debilitating, massive bleeding, perforation, strictures, or obstructions, tissue changes suggesting that dysplasia is occurring, so that's a precursor to cancer, and if carcinoma develops, so cancer. Nursing assessment will involve a history of autoimmune disorders, infections, medications, family history, and symptoms of diarrhea, plus or minus blood, weight loss, anxiety, and depression. Assessment for diarrhea, impaired skin integrity, anxiety, ineffective coping, ineffective therapeutic regimen management, and nutritional imbalance. So nursing care, during the acute exacerbation of IBD, nursing care is focused on hemodynamic stability, pain control, fluid and electrolyte balance, and nutritional support. Nurses and other team members can assist patients to accept the chronicity of IBD. It's a very stressful and anxiety-provoking illness, and learn strategies to cope with its recurrent, unpredictable nature. And that's the piece that leads to the anxiety, is that unpredictability of it. So planning, the overall goals would be to experience a decrease in the number and severity of acute exacerbations for the patient, a maintenance of fluid and electrolyte balance to remain pain-free and improve quality of life. So evaluation, you want a decrease in diarrhea, so fewer, firmer stools, a decrease in anxiety with an improved coping strategies, a maintenance of body weight, no evidence of skin breakdown, and healthy coping behaviors. So teaching, importance of good rest and diet management, perianal care, so this is where the skin breakdown is happening, to monitor for the action and side effects of drugs, but also to teach your patients about the action and side effects of drugs. What are the symptoms of recurrence, when to seek medical care, and the use of diversional activities to reduce stress. So age-related considerations, in the older client with Crohn's disease, the colon rather than the small intestine tends to be involved. There's less recurrence of Crohn's disease in the older client treated with surgical resection, so that's something positive that comes out of surgical resection. And the degree of inflammation associated with both conditions tends to be less in the older adult than in the younger client. And so that is my end for an overview of inflammatory bowel disease and DKA. So please bring your questions to our next Zoom class.